Hi, everybody. I am so happy to be here, and I really appreciate the invitation. And this is my first SCN2A meeting, so it's been really wonderful meeting the families and seeing all of the great things that everybody's doing. So I'm going to talk to you guys about really the more kind of practical aspect of what to do when your child is having a seizure. And, planning ahead to know what you need to do when. So we'll go over some some description of seizure types, but mostly I'm gonna focus on the practical aspects of how to deal with seizures. So I think just to start out, for families who have epilepsy, being prepared and being educated about your child's seizures is really the best way to minimize the seizure risk and maximize your child's quality of life and your family's quality of life. So really my goals today are to help you understand your child's seizure types and the risks associated with those seizure types, knowing the importance of trying to identify the triggers for seizures, tracking your child's responses to anti-seizure medications in terms of their seizure control and side effects, and then, the importance of being able to communicate that to your epilepsy provider. So a lot of that, I know that it's overwhelming to start dealing with seizures in your child. And I think, trying to organize your characterization of those seizures and to try to have a game plan for how you're going to get the information about how your child is having seizures and how they're responding to different treatments is really important and is going to help you work together better with your doctor to try to get things under control. And then we'll talk about how to identify and respond to what is a seizure emergency, to know what's a seizure emergency and what's not an emergency, and then to how to create a plan for seizure treatment so that you can optimize safety and minimize the risk that are associated with seizures. And so within that, we'll talk a little bit about the role of rescue medications and a seizure action plan. So just to talk about seizure types for a minute, this is the current, as Dr. Olson was saying, unfortunately, the names that are used for a lot of things in epilepsy change frequently. And so we're all trying to keep up, and I think it can be confusing to healthcare providers as well as families, what the different names of seizure types are and how they've changed over time. So, and as far as why that happens, that's probably too complicated to go into at this talk. But, I think we can talk about what the current names are and classification. And then in the next slides, I'll also mention some of the other names for the same seizure types that have been used in the past, because sometimes you'll hear a mix of different ways of describing seizures. And none of them are really right or wrong. In my own personal opinion, the current classification leaves a lot to be desired for childhood seizures and the seizures that your children are dealing with, because it just doesn't always capture everything that's happening in those seizures. But that being said, this is the current version. And basically, the classification is divided into seizures that have what we call a focal onset and those that we have a generalized onset, and then those where the onset is really unknown. And in onset, they're really talking about where in the brain the seizure is starting. So where is the electrical activity becoming abnormal? And then how does that get turned into what the child is doing in terms of movements or not movements. So in a focal onset seizure, that means there's one part of the brain that's where the abnormal activity is starting. And you can either have full awareness, so the child is aware of what's going on during that focal onset, during the beginning of the seizure, or they have impaired awareness and they're not really acting like their normal self. So that can be anything from they're not answering you to they're staring, or they're trying to respond and not able to in what's normal for them. So beyond the awareness and the impaired awareness kind of subset of the focal onset seizures, you can either have motor involvement, meaning movements of the body, usually rhythmic, and sometimes that means, a focal motor seizure with intact awareness, can mean the child is just having rhythmic movements of their right hand, for example. And so they're having rhythmic shaking of the hand only. They're aware of what's going on. And so that would be called a focal aware motor seizure. You can also have non-motor seizures. So the part of the brain where you're having the focal onset doesn't have to do with motor control. So, it's in a different part of the brain than what would cause movements to happen. And so sometimes that can just result in confusion or staring, or even, something that doesn't really involve movement, so much, and especially rhythmic, activity of the muscles. And sometimes you can have progression of that type of seizure to a generalized looking seizure, meaning you're having tonic-clonic movements of both sides of the body. So you're having stiffening and then shaking that's rhythmic. So a focal onset seizure can start out with just a movement and full awareness in one's part of the body. And then as the seizure progresses, it can involve the entire body and turn into more of what we would think of as a generalized tonic-clonic seizure. And that's just resulting from the spread of the abnormal electrical activity from one focal part of the brain to the entire brain. So sometimes a focal onset seizure, if you're walking in, after the seizure's already been going on for a little while, can look like a generalized seizure. And so that's something that is important to keep in mind as you're trying to make notes about the seizure types of your child and better characterize, what you're seeing. Because what you can describe that the child is doing during a seizure is going to be very helpful in letting your doctor know what type of seizure that is. So the generalized onset seizures, they all have impaired awareness. So the child is not aware of what's going on. There's activity that's occurring basically all over the brain at once and generating the seizure, hence generalized. And those can be divided into motor seizures where you have stiffening and rhythmic jerking movements, and that's described as tonic, and then clonic. Or you can have non-motor seizures where you have a generalized onset, your awareness is impaired, but you're just staring, and sometimes that's called absence seizure, and that's one of the older terms that's being borrowed there. And then you have seizures where you don't know where the onset is in the brain, that can look like the motor tonic-clonic seizures, or other motor seizures, meaning, and other motor is part of the gap, I think, in this nomenclature, in that other motor can look very different in that you can have loss of motor control, so loss of muscle tone, and that can look like a drop seizure. And so they don't really have that seizure type very well described in this nomenclature, in my opinion. But anyway, that being said, there are a lot of other seizure types where you have impaired awareness and they may not have the rhythmic muscle jerking that the motor seizures have. So these are just some other descriptions of seizures that, words you might hear to describe those other types. So the tonic-clonic or convulsive seizures, that's where the body is becoming stiff. Sometimes the whole body is stiff. You have extension of the arms and legs, and it looks uncomfortable. And often there's kind of a cry or a sound that the child will make during that phase of the seizure. And that, is usually because the diaphragm muscle is contracting, and so that'll push out air, and the child will make kind of this strange cry. And most parents hear that cry and they know that a seizure is starting. And so the body becomes stiff. You can have a cry or not. The muscles are very tight all together, and then you have rhythmic jerking of usually both the arms and the legs. Sometimes it looks less rhythmic than other times, and it just depends on maybe that seizure or what your child's seizures usually look like. And then the child will have altered awareness or loss of consciousness with that type of convulsive tonic-clonic seizure. The tonic seizure we just talked about, you can have that tonic part that really doesn't have a clonic phase afterwards. So those often happen during sleep. Often there are a number of them every night during sleep if a child is having tonic seizures. And they're usually fairly quick. So they'll last about 10 seconds. The whole body is very stiff. Often the child is not breathing during that time because all those muscles are contracted that have to do with breathing. And then after 10 seconds, it's over. And, usually they recover fairly quickly and don't, have what we call a postictal period. There's non-convulsive seizures. Those can also be called dialeptic seizures or absence seizures. So these are all the different terms that might go with that seizure type. And that seizure looks really just like staring. The child is not responding to you or able to respond or even remember afterwards if you're able to ask them afterwards. And then a true absence seizure is something that's usually very short. It only lasts 5 to 10 seconds, and then the child is right back to their baseline. Sometimes kids who have absence seizures will be doing something like eating. The seizure happens, they freeze, nothing moves. They're staring, they don't respond to you, and then they go right back to whatever they were doing. So that's usually a fairly short seizure if it's really a true absence seizure. But sometimes children can have seizures that are longer than that are also generalized where they're not responding, and it's not necessarily fitting into that category of absence. So they can last longer, more like 30 seconds to a minute, and look the same in terms of what the child is actually doing. And then sometimes they can also be very sleepy after that type of seizure. Other seizure types or descriptions are myoclonic seizures, where you have a sudden jerk of the extremities. Often there's no warning that that's going to happen. And so sometimes the child can cry when that happens because it surprises them and it probably doesn't feel great. And it can involve just the arms and the head, just the head even, or just the arms, or the whole body. And then the atonic or drop seizures are really resulting from a loss of muscle tone. So instead of most seizures where your muscles are tightening, this is where they become very slack and the child just kind of falls to the ground like kind of a sack of potatoes, people often say. Or it can just affect their head or the neck, and so they drop their head. And sometimes those types of seizures can really cause injury if you're upright, sitting, or standing, because you just lose all muscle tone, and often the face is what will hit. And so you can have teeth broken, facial injuries and stuff like that from this type of seizure. And it comes as kind of a big surprise. It just happens all of a sudden, and it's over after a few seconds. And then there are the infantile or epileptic spasms, which Dr. Olson was describing as well. They tend to be fairly quick. The actual seizure part or the spasm portion just lasts for a few seconds or, up to 10 seconds. And then they tend to reoccur in a cluster. And that's kind of part of the definition. So if you're seeing your child do the same movement, over and over, and sometimes it can be a tonic spasm and then relaxing, and then 10 seconds later it happens again, and that happens over a period of time lasting usually a few minutes. That would be, a spasm or epileptic spasm or infantile spasm cluster. And then you can have various combination of those names that can describe the type of seizure that your child is having. So sometimes you'll have a myoclonic atonic seizure where you have a sudden jerk and then a fall. So, you can have different combination of those words to describe the type of seizure that your child is having too. So I think altogether, the most important thing to remember is that, if you're trying to describe the type of seizure your child is having to the doctor, you might not even want to use these terms if you just describe what you see them doing. Sometimes that's the most helpful because, as you can see, some of those terms, can overlap, but they can be different types of seizures. And really, the description is really important. So, spending some time before you go to a doctor visit, maybe taking notes or writing down exactly what you see during a seizure can be very helpful and get you further along in terms of having your doctor understand really what type of seizures your child is having. You can also take videos, that's been mentioned in a lot of the other talks. Everybody has a cell phone now. You can take pictures or videos fairly easily. And I think the hardest thing for parents is to remember, that they should do that, because when their child has a seizure, everybody's like, oh my God, what do we, you're kind of in a panic mode, and you might not think, oh, I should take out my phone. I should make a video of this. I should, be looking at my watch. Those aren't necessarily the first things going through your mind. But, I think part of the purpose of this talk is for you to kind of have a way to approach your child's seizure so that instead of just feeling utter dread and panic, you can go, okay, I know what I'm going to do when a seizure happens. I'm going to do this, this, and this. I'm going to try to take a video. We'll be ready for this. And I think that can just, help you as you're, dealing with seizures that are continuing to happen, and come up with a game plan for what you're going to do. So what are the risks of seizures? Why does it matter, that children are having seizures, and what are the main worries in a seizure happening? So the immediate risks are injuries. So if the child is doing something where, an unpredictable, seizure is happening to them, are they someplace where they could fall and hurt themselves, or be injured because the seizure comes out of the blue? And the other immediate risks are that you might end up going to the emergency room or having a hospitalization result from a seizure. And then, the other immediate worries are that if a seizure is happening, and it depends on what type of seizure it is, how long it lasts, and so forth, and the other circumstances, of the child at the time, a seizure can result in respiratory failure. If it goes on long enough, you can have organ failure, and it can really have, a tremendous effect on the body if the seizure is continuing. And so I think just being aware of those risks, is important, not to scare you to death, but, just so that you know what you're dealing with and why you need to respond to it a certain type of seizure in a certain way, because obviously we want to minimize these immediate risks. And then the long-term risks of repeated seizures that aren't well controlled is those that happening in and of itself can be something that can cause further brain injury and functional decline or cognitive decline, in addition to, whatever the cause of the seizures is that may also result in some of those problems. So if your child has SCN2A, clearly they're at risk for functional issues because of the genetic mutation. But, if the seizures are poorly controlled and they're continuing to happen, sometimes that can also be a contributing factor to, how that child is able to function over the long term. And then, another long-term risk of seizures that's talked about more and more is SUDEP, or sudden unexplained death in epilepsy. And that really just means that children who are having seizures and have epilepsy have a higher risk of mortality just because they also have epilepsy. And there are many causes, many reasons why that can happen. But, I think it's something to be aware of. And the best way to decrease that risk, that's a long-term risk, is to better control seizures and to have a plan for what happens if a seizure is not stopping. And then, just diminish quality of life and problems with making developmental outcomes worse than they, would be without the seizures, is another long-term effect. And, really, our goal is to try to maximize that child's quality of life, whatever it can be, and whatever their developmental outcome can be. We want them to get as close as they can to what their full potential is and minimize the effect that seizures are going to have on that. So a lot of these risks that we're just mentioning here can really be improved quite a bit by the use of rescue medications, and having a treatment plan for what you're going to do in the acute setting of a seizure, and a seizure action plan. So I think the best way to prevent and manage seizure emergencies is to understand your child's seizure type. And sometimes children have more than one type of seizure and what those usual characteristics are. And one of the best tools for that is to keep a seizure diary. And a seizure diary can come in a lot of different forms. You can use, an app on your phone, or you can, write with pencil and paper, pen and paper, in an actual diary or a calendar. But some of the things that you want to try to record are what time of day, what time of the month do your child's seizures usually happen? Is there any pattern there that you can identify? Are they happening while the child's awake or while the child's asleep, or during, kind of these transitional times, nap time, or when the child is going from wake to sleep or waking up from sleep? How long are they lasting? So you're timing the seizures and recording, how long did each seizure last? And are they tending to cluster, meaning are they happening, several of them within a few hours? And clusters can be mean different things, as we'll talk about in a minute. And then can you, identify any kind of warning signs that the child is going to have a seizure? So is their mood changing, their behavior changing before a seizure? Are they looking a certain way? Can you identify any warning signs? And then what does the behavior after a seizure look like? Are they very sleepy? Are they slurring their words or unable to respond to you, or unable to do certain things that normally they would be able to do? And then identifying triggers or factors that are more likely to make a seizure happen. So typical, triggers for seizures are going to include when the child is ill, if they're having fevers, and sometimes a seizure can happen with a trigger before you even realize that the trigger is there. And so retrospectively, you might be able to look back and say, well, they were getting sick, and they were coming down with a cold, and that's why the seizure was probably triggered. Lack of sleep or changes in their usual sleep habit or usual sleep schedule can be a trigger. Emotional stress, excitement, flashing lights, loud sounds, getting overheated or being in a hot environment, or getting dehydrated. And those are just a variety of different triggers that not everybody is going to have, but if you can identify what are your child's triggers, that's going to be helpful for preventing them and just getting a better handle on why the seizures are happening. And the other thing that I didn't add to this slide is that a very common trigger is also missing medication. So if they've missed 1 or 2 doses of their medicine, and a seizure happens, sometimes that can be helpful to know, because maybe, the seizure medicine dose needs to be increased. Maybe they've outgrown their dose. Kids are always growing and changing in weight. And so sometimes just missing 1 or 2 doses of medication can be a trigger for a seizure. And certainly if they're not getting the medication, or, something is happening that results in them not being able to absorb the medication for whatever reason, can also trigger seizures to happen. Okay, so I stole a lot of pictures from the Epilepsy Foundation website, and I just want to give them credit. So I encourage you to go online and look at the Epilepsy Foundation website. It's a great resource. They have a lot of forms and things you can download. They have a lot of information there that I think is really helpful for families who are dealing with seizures. And they have this, seizure form there. You probably can't really read it right now, but basically, it goes through just a guide of the things that you should be looking for and recording in a seizure diary. And there are, as I said before, a lot of different ways to do this, and you should really just use a method that works for you. And if it's a method that you can also share with your doctor, that can be really helpful when you go to an appointment. Okay, so what is a seizure emergency? What are the constituents of that? So there's convulsive status epilepticus, and that's a term that means the convulsive or active part of the seizure where, there's a motor convulsion happening and rhythmic activity, and that's lasting for more than 5 minutes. That's considered convulsive status epilepticus, and it's definitely a seizure emergency. A lot of the other, parts of these definitions, really depend a lot on what is normal for your child's seizure. So a seizure emergency is really something that is kind of above and beyond what you're used to seeing. So it's very relative to what your child's experience is. And so really it depends on you as a parent to define the seizure emergency for your child. So when seizures are occurring back to back, the child is really not recovering consciousness between seizures. That can also be part of convulsive status epilepticus. Or if you're having, repetitive seizures without regaining consciousness that's lasting 30 minutes or more, then that's also considered status epilepticus and is definitely a seizure emergency. There are also non-convulsive types of status epilepticus where you can have focal seizures where the brain area involved, like the occipital lobe in the back of the brain or the frontal lobe, where you don't have a lot of motor representation, is having a seizure and it's staying focal in that area, but the child is more confused than usual, is not acting like themselves, and has altered awareness. And most parents are really good at identifying when this is happening, sometimes better than healthcare professionals. So you should trust yourself. And if your child is doing something that, is not right and is not their normal, you should, wonder, is that a seizure that's ongoing? And maybe it's just doesn't have a motor component. And sometimes children can have repetitive absence seizures that can turn into a non-convulsive status epilepticus, non-convulsive. And really, you're only going to have that type of status epilepticus if you have absence seizures and, certain types of seizures. So, and then, as I said, it really just depends on, what is normal for your child and kind of when their seizures evolve to above and beyond what you're normally seeing, that's when you should think about that as a seizure emergency. And seizure clusters, it's really the same. So what's an emergency and what's too much of a cluster? Often children will have as their normal seizure, type that they're having every day, they'll happen a few times in a row. For example, several head drops in a row, and that's their normal seizure cluster. If it's really going on what's beyond in time, what's normal, and the child's not coming out of it, that's when you should really start thinking, is this a seizure emergency for my child that I need to act on? So this is really just basic seizure first aid. It's something that all parents should definitely know about, but it's also something that is very helpful to educate your school about, your neighbors, your, friends and other family members who might be caring for the child. What do you do if your child has the child has a convulsive seizure? And, you can review those steps preferably ahead of time because if you're trying to do it during a seizure, that's not the best time to review this kind of thing. So staying calm, performing the seizure first aid, which is, you want the child to be safe, get them out of harm's way. So if the seizure occurs while you're crossing the street, for example, get off, go to the sidewalk, get the child to a safe place, then turn the person onto their side. And if they're not awake or aware of what's going on, you want to keep their airway clear without putting anything into their mouth. And, being on their side can help anything in their mouth come out easily and loosen their clothing, and, parents often ask me, how do I know what they are aware of during this? And, I don't know that anybody knows the answer, but it can't hurt to speak calmly to them, reassure them. You want to stay calm and provide kind of an influence that if they are having any awareness of what's happening to them, you're there to make them, feel safer and be reassured. And then you can also put something under their head to make sure that if they're having repetitive or rhythmic movements, they're not banging their head on the floor or that kind of thing. And then, you want to start thinking right away, is this a seizure emergency? How long is it lasting? You're timing it with a watch or, a timepiece, your phone. And then if you get to 5 minutes, you have a rescue medicine in place and you're taking the next steps of what you need to do. So if your child's having a seizure where they don't have complete loss of awareness, you can also, follow these steps and help them stay safe. So get them to a safe place. If they know, if, you feel like they're going to have a seizure, get them sitting down, as opposed to standing up. Let them lie down or, get to a place they're not going to hurt themselves if the seizure becomes convulsive. And then, if there are sometimes kids and adults who are having seizures will not be aware of what they're doing and they're having partial loss of awareness and they're just not making good choices. And so you keep them from running out the door or, doing something that could result in them being in an unsafe situation. So sometimes if you have to hold them back, that's okay. And then you don't want to leave them alone and you want to time this because sometimes those types of seizures can progress to a convulsive seizure that's going to be more dangerous. Okay. So when to use a rescue medication. Anytime that you feel like the child is having something that is outside of their norm and is not stopping, then that's when you should think about the rescue medication. If they're having a cluster that's longer than usual, more severe, and certainly a convulsive seizure that's lasting more than 5 minutes, that's when you're going to use a rescue medication. And then, similar, if you're using a rescue medication, often we do encourage you to call 911 or go to an emergency room. And sometimes if the paramedics come and you've given the rescue medication and the seizure has stopped, they don't always have to take the child to the emergency room. But it's good to have them checked out because often these medications can cause breathing problems. So other things that can help improve seizure detection are devices, assistance dogs. There are implanted devices that I think there's going to be another talk later by my colleague about the RNS device. But the VNS is also, a great device in children who are not having good control with seizure medications that can help shorten seizures and make them less dangerous. And often people who have these devices in place will report they don't have to go to the emergency room as often. They're much less likely to be hospitalized. And it can also just reduce, the severity of seizures overall. And often you get more than a 50% reduction if you're responding well to that. So rescue therapies that are available right now. So for rescue medications, the most common ones are going to be nasal route medications and rectal. And then there are also some that are, not necessarily FDA approved, but are used by mouth. And, these on the side with the red square around it are the most common FDA approved medications that are used for rescue. So Diastat is a rectal gel with diazepam. Nasalam is a nasal spray made from midazolam, and Valtoco is another nasal spray medication that can be used as rescue. And then a lot of doctors do prescribe clonazepam wafers or tablets that can dissolve quickly, and they can be put in the mouth, usually not between the teeth, because if you're having convulsive seizure, there tends to be, clamping down of the jaw, and you don't want to get bitten, but they can be placed in between, the tablet can be placed in between the cheek and the gum. And then you can also, rub the cheek once the medication is in there. But basically, these all usually work fairly well. Some work better for some children than others. And sometimes you have to do a little bit of experimenting to see what's the best rescue medicine for your child and the circumstances that you're in. Nasal sprays are much easier to carry around with you. Diastat is a rectal gel, so, it's not always socially the greatest for teenagers and that kind of thing. But, for smaller kids and babies, sometimes it's the easiest way to get a medication into them quickly that's going to stop a seizure. So, I think you can talk to your provider about which is best for your child and, any side effects or things that you want to, make sure you know about ahead of time. But I think the most important thing is that you have a rescue therapy that's in your hand, that's available, that you have with you, and you know where it is, and you've looked at it before a seizure happens. Sometimes parents will tell me, well, he had this seizure and, we didn't even know where the rescue medicine was. I had never gotten it out of the box. I had no idea how to, apply the rectal medication, and so I didn't use it. So, having a plan before the seizure happens is really the best way to go. And planning when you're calm and, you're not in the heat of the moment is going to work much better than if you're trying to figure it out when a seizure is happening right in front of you. So a seizure action plan, is something that most doctors are going to provide to school-age children especially. But you can also use it if your child's not in school. It can be used for daycare. It can, really just be something that you're giving other caregivers. And, I think filling it out and going through it with your doctor really helps you prepare for a seizure as much as anything. But it also gives you a way to help others, who may not be taking care of your child all the time, to understand what they're going to do if a seizure happens for your child, and what the steps are that need to be taken. So these are a few forms that are on the website of the Epilepsy Foundation. I think, they're really helpful. You can print them out yourself. You can take them to your doctor's office. Often doctor's offices, is epilepsy doctors will, like for example, this is seizure action plan season for our office, and we're filling out hundreds of these every day. And it's a lot of work for staff and the doctor, but it's really something so important that's going to help you at the beginning of the school year, for your child to have this in place. And to talk about it with your doctor is really, I think, very important, so that you understand and they understand, what is going to happen when a seizure is occurring, what's a seizure emergency, when rescue medicines need to be given, when 911 needs to be called, and so forth. And it really also serves to educate those other caregivers so that they're prepared for this, whether it's a swimming coach or, the summer camp program or whatever it is, it gives them a document that will help them understand what to do. And it really can provide peace of mind for you and for those other people caring for your child. So this is really just my summary of what you should hopefully take away from this. It's really important to know your child's seizure types and to be able to describe them to healthcare providers, whether it's the emergency room physician or your epilepsy doctor or your neurologist or your pediatrician. And sometimes the best way to do that is to describe exactly what you're seeing or to take a video. Keeping a seizure diary can be so helpful. And, I think it's helpful for the care plan in general for your child, but it's also helpful for you to help you understand what you're seeing and to try to make sense of it, so that you can talk to your epilepsy provider about it and get a better handle on when seizures are happening and what treatments are going to work best. And then, know what's the usual seizures for your child and plan for the unusual. Have a rescue medication, know where it is, know when to use it and how to use it, and have a seizure action plan in place ahead of time. And then, if you can do all these things, you're helping yourself, you're helping your child, and you're really helping the community to understand what's going on better and how they can keep your child safe. And, it really can empower you as a family, and it really empowers your child, to reach out to others and try to teach them more about your child's seizures and what they should be doing. And then, as you educate yourself about your child's seizures, you can help to identify triggers for them. You can be aware of what changes are going to make it more likely for them to have a seizure, and you can try to prevent those things and find ways around them so that they're less likely to have a seizure and they're going to stay safer and have a better quality of life. And then last but not least, I think this is something that I'm really glad other people are giving talks about today, but having a child with SCN2A and having a child with epilepsy is really, it's a lot, and it's a lot of burden for you as a caretaker and as a parent. And, part of being a good caretaker for your child means that you have to take care of yourself. And, I think this is, planning ahead and trying to be organized about what's happening and what triggers are is going to get you much further in that direction. But, being healthy, being well rested and calm during a seizure, knowing what to do ahead of time is going to make everything better and safer as you go through. that journey with them. So thanks so much to everybody. And if anybody has questions.
Thank you, Dr. Von Allmen. Any questions in the audience?
So my son lately has seizures during eating, and you have talked about triggers. So I want to ask whether it could be, because we thought first that it could be some stomach pain, but ultrasound is good, nothing special, whether it could be connected with seizure.
I mean, there are certainly certain triggers like chewing, eating, that for some children can be a trigger for their seizure to happen. But sometimes, it comes down to, what kind of seizure is it that's happening while he's eating? Is it sometimes it's just you're looking at him more because he's sitting at the high chair, or you're with him there watching him closely. And so sometimes it's just a common environment for people to identify seizures. So, I think, working out those details is helpful, just by observing, and you can also try to figure out, is it certain types of meals that tend to where you see seizures more?
It looks like it started like aura, and then he has tonic-clonic like spasms, and he even cry like, yeah, something like some like he has some pain, but again, we're not sure.
Yeah, I mean, certainly if the child is somewhat aware of what's going on, a seizure can be painful because they really can't control the muscular contractions that are happening. And, so sometimes if they're partially aware, it might make them cry or look like they're in pain. I think it's probably worth, keeping a seizure diary, trying to figure out, different circumstances when those are happening and talking to your doctor about it. Um, Most likely, if it's a tonic-clonic seizure, it's not caused by, stomach discomfort. It's more the other way around. After the seizure, they may be, feeling sick at their stomach or nauseous, or having vomiting afterwards. And it might just be circumstantial that it happens during mealtime. Um, so, I think you can work those circumstances out, but um, yeah, I mean, it's not real common to have, eating as a trigger, but if your child is, having trouble with chewing and swallowing, or, there's something that is too challenging when they're eating the meal, that could be stressful and maybe could be a trigger in itself too. So I think those are all things to be aware of, and should help you work that out.
Thank you.
With all the different types of epilepsy and the different levels of acuteness of them, do any of these, and I've experienced having to deal with my wife at one time when she had it. No more. It was an accident, and I remember having to really protect her physically. There wasn't anything said about, does any of these areas of epilepsy cause permanent brain damage? To where something else can happen and get worse and not be corrected.
So I think it's important to keep in mind that most seizures are going to be self-limited, in that the brain, has a seizure and then it turns the seizure off on its own. And so most seizures are going to last maybe a minute and a half to 2 minutes, if they're a convulsive seizure, and then the seizure stops on its own. And when the seizure stops on its own, that particular seizure is not going to cause brain injury in and of itself. Seizures that are lasting longer than 30 minutes and are convulsive can, kind of the brain is using a lot of energy to have that, rhythmic discharge in the brain, and the body is also, using a lot of energy to have a convulsive seizure for that long. And so sometimes you can have brain injury when a seizure goes on for a long period of time and is convulsive. So sometimes you can have injury to the brain cells and to areas of the brain during a long seizure. But usually that would be a seizure that's lasting 30 minutes or more and is convulsive and involving the whole body. Most of the time, individual short seizures are not going to be a risk for any brain injury. Sometimes over time, if you're having uncontrolled seizures where you're having either short or long seizures that are occurring daily, for example, that can take a toll on the brain and cause, more of a long-term injury in how those brain cells function. But in terms of, immediate brain injury, most seizures that happen that are short are not going to cause any permanent injury to the brain. It's the longer seizures that don't stop that are the ones where the brain is at risk for injury from the seizure itself.
Great. Thank you. That was a clearer explanation.
Okay, good.
Comment and a question myself. Ooh, up there. But one thing I just wanted to mention is that you mentioned seizure action plans, and one thing that we found very helpful is to put together context-based seizure action plans as well, like one for the ER or one for school, and they're different. And particularly for ER ones, to re-up that while heading into the ER, for a second, third line for the hospital, we found that to be incredibly valuable.
Okay, I have two questions. First is adding to his question. Actually, my son is had severe epilepsy during his early months, like having 20 or more per day. But now I think he is finding his medication and he's well controllable, like once a week or under 5 times a week. So me and my prescriber is really happy for that. And I think we just are settled at that moment. But do you think we need to go for the seizure free, or we should stop and see him grow further, because he is 50 years old, but still a neonatal development stage. So I want to ask your advice on those kind of balance. And the second question is actually I heard that your institute is a multidisciplinary center for SCN2A. So I'm just curious more about your institute. What are the advantages or like services that we can expect as a patient? So yeah, if you can elaborate on that, thank you.
Okay. Well, so for the first question, I think what's acceptable for your child's seizure control, depends a lot on the circumstances. So for kids who have SCN2A, sometimes it's worth talking to your doctor about what the expectations are, whether you really want, and expect the child to be seizure free or not. And I mean, everybody wants seizure freedom for sure. And that's what everybody should be striving for. Sometimes it's possible and sometimes it's not, and sometimes it depends on the period of life that the child is in, what phase of development they're in, whether seizures can be controlled or not. But I think, keeping seizures as short as possible, so and having less motor involvement, less problems breathing during the seizure, those are all aspects you can work on improving, even if you can't get your child to the point where they're not having any seizures. If the seizure is lasting less time, involving, less of the body, for example, and not, involving breathing issues and that kind of thing, those are all going to make the child safer during a seizure. So, I think it's a process you have to go through with your doctor. And, there are times where depending on your expectations, maybe you're already at, the best you can expect for the seizure control. But, I think it's better to talk to your doctor about that than just, well, we'll just wait another 6 months and he's having 5 seizures a week. Maybe there's something that can be done to improve that. And so I think it's always better to talk to your doctor, to have clear lines of communication about what's happening, what the seizures are like, keeping a seizure diary. And, that's going to help you get to whatever your child's full potential is for seizure control. And, a lot of children with SCN2A who have epilepsy, it's very difficult to control seizures. And so, using the right medications for the condition, that's going to help. So, educating your doctor about SCN2A, we've talked about that a lot. Making sure you're trying the right medications that are more likely to work. And then if medications are not working, taking the next step beyond medication. So thinking about things like the ketogenic diet, so non-medication options, thinking about the vagal nerve stimulator, is your child a candidate for those things? And should you consider them in terms of the treatment steps? So, I think it varies from case to case, what is the best seizure control for your child and what should you be expecting? But I think pushing your doctor and, trying to get those answers and not waiting is always better. And in terms of the second question, we recently, at University of Texas in Houston, started a multidisciplinary clinic for SCN2A. Our goal is to try to provide an experience where you can have your records sent ahead of time and we kind of see what kind of evaluations your child might need, what kind of doctors they might need to see, and try to group all that together in a visit for you. So, combining, epilepsy doctors, neurodevelopment specialists, GI specialists, ophthalmologists, things like that, things that, some children with SCN2A would need, and try to get a comprehensive evaluation with genetic counseling and so forth. And, then the secondary goal of coming to a center like ours would be, we're going to be more up to date on what kind of research studies are available at our location or at other places, with our colleagues, and, providing education to you about that and giving you opportunities to get involved in research. So I think, you can, we have an area where other members of the team are doing, some various testing and evaluations for research purposes that you can go check out during the meeting here. And you can certainly contact us at any point if you want to come for an evaluation, and we can, talk about what that would be like. And, we want to make it worthwhile for families to come, and have it be something that we can help your doctors locally as well, as your care continues, to kind of be as well educated about your condition and make sure you're doing everything that you can and should do, for your child, considering the SCN2A specifics of what's going to work, what doesn't work, that kind of thing.
All right, any more questions? I think we're going to wrap it up and go to lunch, but thank you very much, Dr. von Allmen.